Okay, thanks a lot. I'm very excited about this meeting. I want just to express my sincere thanks to Professor De Rico and the institution of the region that allowed the realization of this important meeting. Yesterday, during the dinner, we said maybe this is the first, but there will be many others in the countries of our colleagues and friends. As a geneticist, I just briefly said that I fully agree and believe in the collaboration and in the multidisciplinarity of this topic among colleagues. And I want just to say that Professor De Rico created this fantastic network in the region with the aim of a better care for patients and their families. And thanks to all of you to be here and share your experience with us. So I'm very glad to introduce Alice, Dr. Alice Krebsova. She will talk about the precision phenotypes in cardiomyopathies.
Thank you very much for introduction. I feel as well very much honored to be invited here and to be able to talk about sudden cardiac death and cardiomyopathies. I'm a cardiologist and a clinical geneticist and working in the Center for Inherited Cardiovascular Diseases in main transplant center in Czech Republic in Institute for Clinical and Experimental Medicine. And at the first part, I would explain you the phenotyping in cardiology based on recent guidelines, because we as cardiologists, we have guidelines for everything, and they are regularly updated, as you probably know, and we have to follow the guidelines. And the very recent guideline on cardiomyopathies, they are rather new for us, because they base the phenotyping mainly on MRI pictures of these cardiomyopathies. And so according to the last guidelines, we just differentiated mainly a hypertrophic cardiomyopathy, which is characterized by thickening of cardiac walls, as you all know. Then we have a dilated cardiomyopathy, which is, on the other hand, a thinning of a cardiac wall, dilating of a ventricle. It looks like a football, and it's associated with reduced ejection fraction in all individuals. Then there is a very new entity. It's so-called non-dilated left ventricular cardiomyopathy, which is for me just equivalent for a formerly used term of arrhythmogenic cardiomyopathy of a left ventricle. And it's mainly associated with the DNA variants in desmoplakin or desmine. And this cardiomyopathy is characterized by late enhancement areas of a non-dilated ventricle, which has almost normal or very mildly reduced ejection fraction, but is associated mainly with ventricular arrhythmias, who may be life-threatening ones. Then the fourth type of cardiomyopathy, which we have to talk about, is arrhythmogenic cardiomyopathy of the right ventricle, which should be characterized by a fibrofatty replacement in the right ventricle, and which leads to a dilation of the right ventricle. And first of all, at the very beginning of this disease, this is a very much life-threatening disease. Without structural changes at the very beginning, it leads to a life-threatening ventricular arrhythmia, typically in sportsmen, in athletic persons, and it has very reduced penetrance, but in sport it is very penetrant. The very last, fifth type of cardiomyopathy, according to the new guidelines, is so-called restrictive cardiomyopathy. It's really a rare disease, which at the first glance, there are normal sizes of ventricles and normal sizes of ventricle walls, but not the ejection fraction is affected. There's the ventricle, the walls are very hard. They are not flexible anymore. So there's a diastolic dysfunction of the left ventricle. Maybe you've heard about it. That in cardiology we talk about the cardiomyopathy or heart failure with reduced ejection fraction. These are all other ones. And then we talk about the heart failure with preserved ejection fraction. It means there is a diastolic dysfunction, and this is the cardiomyopathy, which causes a very severe diastolic dysfunction, and you may recognize this on dilated atrium, which leads to first atrial arrhythmias and later on to pulmonary hypertension. Sometimes patients come with pulmonary hypertension, and then we find out that they have a primary disease, is restrictive cardiomyopathy. In the guidelines, there is the patient journey very nicely described. So they say maybe you just see the patient who comes with dyspnea on exertion or with palpitations or even a syncope or even a cardiac arrest, maybe survived, or when not survive. The very important thing is family cascade screening. The whole cardiology and especially inherited cardiac diseases are associated with a very high risk of cardiac arrest, and that's why we are here. That's why it's important. So it means if we state the diagnosis at the patient, the second we can't let him stay there. We have to offer the family cascade screening because there is a high risk of cardiac arrest, which doesn't need to be survived. Sometimes we encounter patients who have just the incidental findings of abnormal ECG or murmur or arrhythmia. And then we have to do a very careful diagnostic workup based on morphology, echocardiography or MRI, as I showed you. And then further, it's important to have a very good tissue characterization. So there are recommendations to do a biopsies, which may help us to make exact diagnosis. And based on that, then we state the phenotype of those cardiomyopathies, as I showed you before, and it all after taking as well or making a pedigree analysis, genetic testing, analyzing whether there is some extracardial involvement, there can be some syndromic diseases. Based on laboratory markers, increase creatinine kinase or troponin, and based on pathology we then can make exact phenotype, and based on that it can lead to integrated etiological diagnosis and individualized therapy. This is one of the central figures of the guidelines, which says how important a multidisciplinary approach to cardiomyopathies is. There are genetics is mentioned at least twice, and there are also pathologists and forensic doctors part of these multidisciplinary teams, because you help us with histology sampling and as well with stating the post-mortem diagnosis of a possible inherited disease or cardiomyopathy. So it's very important, and multidisciplinary approach is very important as well for living patients, not only after a sudden cardiac death. As you already saw here and heard the histology is very, very important. This pathologist or histologist can tell us whether there is a myocarditis present, but we know that the myocarditis may mimic inherited cardiac diseases. Well, there are many patients who suffered from myocarditis in childhood and can come with a dilated cardiomyopathy later, but they have in fact inherited cardiomyopathy. So myocarditis, we have to be very careful with stating this diagnosis. Of course, maybe you find a sarcoidosis, which is not very easy because it's a focal process, and sarcoidosis can mimic mainly arrhythmogenic cardiomyopathy of a right ventricle. And what you may be very, very useful to us cardiologists if you state the diagnosis of myocardial storage disease. This is a very important group for us of diseases because we have right now enzyme substitution therapy. For example, for Anderson-Fabry disease, this is sphingolipidosis. We have it for Gaucher disease, Pompe disease, and very important, we have such a therapy for transthyretin amyloidosis, which is in form of inherited one and senile one. And right now it's so important because we have the therapy and it's feasible for our patients. So this is histology is a part of a phenotyping. As well, we know that the genetics is a next very, very important part of phenotyping, or rather genotyping in cardiomyopathies. And we know that at least 1/3 of cardiomyopathies are mainly genetically inherited type of a disease or pure genetics. And the other thirds, somebody has probably some trait and it's enhanced through their lifestyle and it leads to a cardiomyopathy, or there are probably as well complex genetics, risk scores and causes of cardiomyopathy, especially for individuals who get ill in an older age, over 50 years of age. And the genotyping is very important for cardiologists because on genotyping, the cardiac arrest risk assessment, this is what we do on a daily basis. We decide whether the living patient needs to have an ICD just to prevent a sudden cardiac death. And so the gene assessment is very important, and based on genetics we have risk scores. For example, we have for arrhythmogenic right ventricle cardiomyopathy, we have a risk score which tells us whether we have to implant or not, and this risk score applies mainly to plakophilin 2 gene. We have a risk score for laminopathies, for lamin AC. We have a recently risk score for desmoplakin, which are important genes for arrhythmogenic cardiomyopathy. We have as well a sudden cardiac death risk for HCM, where the genetics is probably not as prominent, but if you read the small letters under the risk score, you may find out that this risk score does not apply to a certain genotypes, especially to Anderson-Fabry disease or certain glycogenosis, which have another risk scores or a risk for cardiac death. Genotyping is as well very important for further assessment of disease course in your patients, because there are patients who, after diagnosis, after establishing heart failure therapy, they are stable for many years or even decades, but there are patients whose course will decay very quickly, very fast, and we have to think about putting in on the waiting list for heart transplant, for example. And this is the recent work of our group, where my colleagues collected over 600 patients with a recent diagnosis of dilated cardiomyopathy. And we know now that according to a genotyping, if they are carriers of non-titin pathogenic or likely pathogenic variants, they are very much in danger of further decreasing of ejection fraction and will need heart mechanical support or even a transplant. Genotyping has an as well impact on clinical practice in form of assessment of a disease course of asymptomatic genotype positive relatives. As I said, family cascade screening is a very, very important thing in cardiogenetics. And as well, there is the important role is as well in genotyping. If we know that the person, it's a male, a relative, young son of our patient, and he has a laminopathy, then we know that he has a very potentially very life dangerous disease, or he has a truncation variant in filamin C, then we are managing him in a very different way as a female carrying a Titin variant who is probably in a very low risk of developing a heart failure in her life. So this was the very first part, and right now I would like to share our Czech experience on post-mortem genetic testing, which we are performing on regular basis since 2018 until now. We could completely analyze, means family cascade screening and cardiogenetic screening in 172 cases. As was already shown, males are prevalent in our cohort, and mean age was 33 years. And here you see the most prevalent post-mortem diagnosis was sudden arrhythmic death or sudden unexplained death. It means that the person had some changes, but they didn't reach the diagnostic criteria for a certain cardiomyopathy, or they had a generalized atherosclerosis, but it was not a stenosing atherosclerosis. Then these both diagnoses post-mortem are followed by a diagnosis of arrhythmogenic cardiomyopathy, which, as I show you later, probably in our cohort is a rather cardiomyopathy of obese patients, or those who who drank a lot of alcohol. And then hypertrophic cardiomyopathy, this is aortic dissection. These are aortic dissection persons, dilated cardiomyopathy. We had all over the years, we had only 9 cases of sudden infant death. Maybe surprising for you, or I don't know if you have the same experience. The families of very small children, they often do not want a post-mortem diagnosis. They are not interested in that, and if they want it, they come and they are already, the female is often already pregnant, which is good for her, but maybe it's a next child at risk of sudden infant death on the way. We as well started very recently with screening of young persons after acute myocardial infarction, because we work closely with Czech Society for Atherosclerosis, and we as well wanted to try to see whether there are some as well true arrhythmic genes in those who died of myocardial infarction. Our results, we have a detection yield of detection rate of PLP variants in 22% altogether. The mostly identified gene is Titin, followed by collagen 3A1, which is vascular Ehlers-Danlos syndrome. This is unfortunately a terrible disease, and I know almost only dead persons with a acute dissection, Ehlers-Danlos. And then followed by filamin C. This is arrhythmogenic cardiomyopathy. RY, R2 are CPVT individuals, SCN5A channel. These are sodium channelopathies, KCNH2. This is a long QT type 2, and YBPC. This is the next very frequently found gene in mainly hypertrophic cardiomyopathy, but there's also some individuals with dilated cardiomyopathy caused by mutations in this gene. We have a positive family history in almost 44% of all families, and if we analyze only the families with a positive family history of sudden cardiac death or cardiac arrest or a cardiomyopathy or any inherited cardiac disease, then the genetic yield is 37% increases to that. So that's probably why in some literature it's proposed that first, after sudden cardiac death, if you as a forensic or pathologist make the diagnosis of possible inherited disease, that first you analyze the family, and if you find a positive family history or a disease in a living relative, then you go to a molecular diagnosis. It's as well a possible approach, especially if you want to somehow work very effectively. But anyway, at least in our cohort, we would use some sporadic cases, which were as well somehow very surprising. If I show the genetic yield according to an autopsy diagnosis, because our forensic doctors, they just started with that before 2016. For them, it was just important that the death was of a violent cause or not a natural one. And then we started through discussions, teaching. We as well make multidisciplinary meetings instead. Then they just learn more and more. I'm not sure whether they do the histology as good as you showed it here, but they are doing their best, and I have to praise them, because here you see how is the genetic yield in different post-mortem diagnosis. The blue one are the genes for cardiomyopathies. The orange ones are the genes for arrhythmic syndromes. Here in the middle, it's a non-compaction cardiomyopathy. It was only one case. So just don't look at that. But you see that we have about a yield of 22% in post-mortem diagnosis of hypertrophic cardiomyopathy, even higher in post-mortem diagnosis of dilated cardiomyopathy. We as well, corresponding to a post-mortem diagnosis of sudden arrhythmic death, we find only arrhythmic genes. So it looks quite good. In sudden unexplained death, it was mainly concealed cardiomyopathy, and in some cases as well, the arrhythmogenic cause. But here is in the middle the diagnosis of ACM. Maybe you remember it was the third most stated diagnosis post-mortem, and I believe we have a very low yield, and I believe in our cohort it's not really the post-mortem diagnosis of arrhythmogenic cardiomyopathy doesn't correspond to an inherited cardiomyopathy, but these were individuals who were older, who were obese, and who as well enjoyed alcohol a lot. Maybe you know, in Czech Republic, unfortunately, we drink a lot of beer, and we are the second one after Belgium in the consumption of beer. So it's as well one of the causes of fibrofatty replacement in the myocardium is alcohol consumption. In SIDS, interestingly enough, we did not really we had only 9 cases analyzed, and we did not find any arrhythmic syndrome, as it is said in the literature. Both cases which we identified, the one case was a very rare epilepsy with a frontal epilepsy associated with apnoea in small children, and the second one, it was a very rare autosomal recessive metabolic disease as well associated with apnoea. 2 minutes. Okay, I'm already. This is for genetics. This is the genetic architecture of cardiac arrest in Czech Republic. We have almost 400 cases analyzed. This is a survived cardiac arrest and not survived. And you see the leading causes: arrhythmogenic cardiomyopathy of the right ventricle. These are mostly sportsmen, and all of them survived. The orange ones are the cases of non-survived. The second cause are arrhythmogenic syndromes as LQT2, SCN5A, and CPVT. And the third most frequent in our cohort are TITINs, which was rather surprising for us, because TITIN is the most frequent cause of dilated cardiomyopathy, especially in males. And we did not suppose that it has such an arrhythmogenic potential. In conclusion, cardiomyopathies require multidisciplinary workup, inclusive of genetic testing and autopsy diagnosis. Genetic testing may lead to individualized cardiac arrest assessment in PLP variant carriers. Genetic yield in cardiomyopathy or sudden cardiac death, at least in our experience, is maybe quite low. We are able to find variants in 1/5 of the patients, maximum 1/3. And forensic doctors may play a very crucial role in recognizing the potential inherited diseases upon autopsy, because it is said in literature that most than half of inherited diseases, their first and the very last symptom is a cardiac arrest. And as it was already said, it's really crucial that the forensic doctors retain the material. We as well take a spleen, as Mary Shepard mentioned here, because it's rich in nucleated cells, and it's as well important and not as easy for our forensic doctors, as they say, is to find the family and contact the family. And this is all. Thank you very much for your attention.
Thank you very much, Alice, for this very nice presentation. I mean, I'm very happy that we all share the same protocols, we all share the same concern, and also we are quite aware that it's very important to also involve families and all the relatives of the dead guys. So I'm very happy to invite now Prof.ssa Ersi Kalfoglou. The title of her presentation is Ethnicity and Sudden Cardiac Death, Who's Risk and Who's Protected. Thanks a lot.
Thank you. Thank everybody that contributed to this magnificent symposium. And I'm extremely happy that I'm part of it. Additionally, I'm very, very happy that I was able to, as the Balkan Academy of Forensic Science, to be a partner of this very important get-together. So thank the organizers, thank you very much. Now, when we say ethnicity and sudden cardiac death, who is at risk and who is protected, it's, you know, a very strong starting point. But what I would like you to think about is that I will be trying to give you a population genetic understanding of this and not more specific things. Yeah, this is me, okay. I'm coming from Istanbul, Turkey. My name is Ersi Kalfoglou. And at the moment, I'm working for a university in Ankara, which is the capital of the country. The whole day we're talking about the different genetic makeup that may be related to sudden cardiac death, which is a major public health issue. I am not going to talk about all these markers that I've given to you. The only thing that I would like to tell you is there may be a difference in your mind. You might not understand exactly what's going on when we say that we have 100 and something markers and we are talking about 4,000 of I don't know what. This is because for each gene that we're talking about, we are trying to focus on different single nucleotide polymorphisms, which makes the number extremely big. Still, the number is not that big based to the technology that we're using today with the next generation sequencing and the automatization of everything. Therefore, it is okay and it is easy. Would you please tell me when to stop?
Yeah, don't worry.
Okay. Where do we get information from? From genetic screening, which is generally not done, unfortunately, with molecular autopsy, which is unmowed those days. Still, the number of information, the information that we get from this is not what we really want. And hopefully we are going to talk about gene therapy, which we are not at the moment. Therefore, our recent findings, as you have seen, are very, very limited. By the way, when we are talking about sudden cardiac death, there are other, of course, not only the genetic part of the whole thing, but we have other roles like the environment and the lifestyle. All these combined will give us an information that we really want. Now, there are ethical and psychological implications. Those make the topic of the next symposium that will be organized in Trieste. So it is a very, very big issue, as you can, some of you understand. we, at least myself, in my university, we take care, I mean, we are encountering lots of problems related. And certainly, whatever everybody said today, it is a multifactorial work that has to be developed in cooperation with everybody. So I said that by the way, I'm like that because you see I'm a very tall girl. Otherwise, I cannot see you, so I'm standing there. I hope you can hear me, right? Okay, thank you. So when we just look around, look what's going on all over the world, we see clear differences, ethnically speaking. When I wanted to summarize the whole thing, I have literally seen that African Americans show 2 times more possibility based on genetic for sudden cardiac death, whereas Caucasians are considered to be regular. South Asians, when we're talking about India, Pakistan, Bangladesh, and the area over there, is again at risk. Whereas when we go to the East Asia, where we have China, Japan, and Korea, we see that the possibilities get lower. Therefore, there is a geographical distribution, there is an ethnic distribution that we can consider and we can think about, which means it is important. Now let's come to the Balkan area, which is considered to be our real subject. Now, it is unique as genetic history and as demographic situation. And we have lots of things that we can study related to sudden cardiac death, as lots of colleagues before talked about before. Do we have the required information, or do we have the required research related? We don't, because of different things, like we have differences in the healthcare infrastructure, economic conditions, scientific resources around the countries in Balkan areas. Therefore, it's not very easy to deal with this issue. Of course, we need collaborative studies, and we have, I believe that we have the possibility to study collaboratively, and I think that projects involving this issue in the Balkan area will consider to be important and can be developed. I will not talk about the opportunities that you all know and we have talked about, but what I did was to try to find some comparison issues related in between the Balkan countries. The answer is I wasn't able to find anything. I mean, the data is really very limited. So I tried to compare whatever I have. So I compared 2 countries with Greece. So I compared Greece and Croatia. And I will give you an example to show you the possibility of difference and what that can be. I found a real difference between Greece and Croatia in something that is related to me as a forensic genetics professor, and I would like to share it with you because the information for this is present. It is a Y chromosome haplogroup. This Y chromosome haplogroup that we are actually using in forensic genetic case identification or paternity cases, this haplogroup is in a very elevated percentage in Croatia, and actually it seems to be the highest in all Europe, whereas it is quite lower in Greece. What does that mean? Why am I giving you this example? The reason is that I would like to show you that there is a possibility to have differences in different countries within the Balkan area, which means we will have to develop different strategies in different countries based on the information that we get on this issue. Therefore, we need to study, we need the information, let's study. Okay, I tried to compare Croatia in sudden cardiac death issue, genetically speaking. I found a limited information. But what I have found is that there's no comparison between these two countries because what they study and what the others study are not matching. So we have an information related to Croatia. There are some studies in Croatia, but they cannot be compared with Greece because they're different in content. Hopefully, both countries will match in the future. I have to repeat that there is quite a good information coming from Greece related to this issue. Then I tried to find something in Bulgaria. Again, the information is quite limited. However, it's promising because what the Bulgarian scientists do match with the Greek scientists at the moment. Therefore, maybe in the near future, we are going to have more information related to these two countries. Certainly, this does not mean anything. Certainly, we need much more information. So, my topic was who is going to be protected? Nobody is going to be protected. First of all, let's say it, state it this way for a generalization. So no ethnic group, talking with related to ethnic groups, no ethnic group is 100% protected. Certainly, there may be lower risk for one ethnic group and higher risk for another ethnic group, which means we are going to develop different strategies in one and different strategies in the other country when we try to deal with this very important issue all over the world. Now, genetic factors may be the reason for differences. Obesity and hypertension, etc., are things that you my dear colleagues, you all mentioned about. Therefore, I will just say that protection is not for granted. However, I have one last example. Finishing? Okay. I'm good. Admit.
Yeah.
This example is interesting because in this example, we have a gene that although it was going to be bad and be a cause or a helper for sudden cardiac death, all of a sudden, in some populations, this gene is stopped by a mutation. So it is deactivated. Generally, we're talking about activations and bad activations, because all activations are not bad. In this case, we have something that closes up the gene. This closing up is much better for the cases. This is a study that I have done, I have seen, and it was very interesting. And when you said protection, I have to talk about protection. And this was, I found it to be quite interesting. And finally, we have to talk about that everybody did know what's going on in the genetic makeup so that we will help the families to, just a second, okay. Okay, we have to find out what's going on with the family so that we will help them. However, you know, my colleagues in Turkey continuously ask me, okay, find the kit, put within that, I don't know, 11, 12, 13 genes so that we will type them and we will find out the reason of negative autopsies. So this is the expectation. And this is not the case. Or it may be the case, but we have a long way to go. Thank you for inviting me. Thank you for listening to me.
Thank you very much.
At the end.
It is a dream what you just mentioned, yes. But we hope that working together. Sure. I'm very happy for this presentation because you highlighted also the we spoke even yesterday evening about the differences about in ethnic groups, and so considering that we are analyzing even here in Trieste quite often patients coming from all over the world, so we have in genetics we have to consider the ethnicity, and also, as Professor Shepard mentioned before, the gender medicine has an extremely important role, so we should also consider that. So thanks again, and please.
Thank you for the invitation. I'm Karin Writzl, coming from Ljubljana, from Slovenia, and I'm clinical geneticist. So I will start with the pedigree and with the reason. That's a lady at 40 years of age that was referred to genetic department. She survived the cardiac arrest. And when we started to draw this pedigree, her brother died at 27 years, her father at 31, and another two uncles at 33 and 40 years, all because of sudden cardiac death. And when you see such a pedigree, you say, what's going wrong? Why haven't we found this family before? And she said, my brother was in Italy when he died, and all my family lives in Macedonia, so I'm the only one living in Slovenia. And that's what I think why it's so important that we are all together here, also not just to share our knowledge, but also to meet each other, because I think we will need to share also information to help our families, because if you think that you find a lot of rare variants in such a case, segregation is very important to go on. So my talk will mainly focus on those that survive cardiac arrest, and I'll start with who of those survivors should undergo genetic testing. Actually, I don't have a clear answer. I know there were the guidelines that were published from the European Cardiology Society 2 years ago. And if you read that guidelines, it said something like this, that if there is suspicion, an indication that there might be a genetic disorder, genetic testing should be done. But if the evidence is not strong enough, it should not be done. But I think it's in real practice, it's difficult to say when it is not strong enough. I put this workflow that was published last year in Lancet, and as was already said, the coronary angiography is done as the first because it's the most common cause of sudden cardiac arrest. But we have already heard that there might be double diagnosis, so it's not good to stop here if there is a suspicion there might be something else going on. It's the same with myocarditis, as we have heard in the previous lecture, that there might be something else going on in myocarditis as well. So there's a family history. If it's positive, it's very good. We have quite a similar percentage that was here before as well in a small cohort of patients who survived sudden cardiac arrest and have, in addition, either some subclinical or clinical features of cardiomyopathy. Then the age. In our cohort, it was between 15 and 71 years. When we read the articles, it's sometimes that they look especially at the young ones, because we know that in young ones, there's the higher genetic yield, although it's mainly due to arrhythmias, inheritance, and for the cardiomyopathies, it's usually the later age that we get them. But in this our cohort, I may say that the youngest one and the oldest one were found to have the genetic variant causative for their disorder. So if we now look more into the cardiomyopathies, it's usually that ultrasound and MRI and ECG that somehow pointed towards this suspicion that this might be cardiomyopathy. This is the range of cardiomyopathies that were found in the patients that were referred with who survived the sudden cardiac arrest. But what I think is also important is what's written here, that even if there is no diagnosis found, one might still consider to refer this person to the inherited cardiac disease. That's mainly because of these concealed cardiomyopathies, where arrhythmia might be the first event before we see any structural abnormalities. So if we now look which genetic test to use, so you are all aware that there are different tests. Each has some pluses, it has some minuses. It's always like this in life. If I say from our perspective, we started with cardiogenetics in 2010, and first we started with panels. We sent this abroad till 2014, when they started to do the genetic analysis at our facility. First it was clinical exome sequencing, then it was whole exome sequencing, and lately we mainly still do also whole exome sequencing, but also in some the whole genome sequencing. Looking back at those panels at the beginning, T10 was not on the panel because it was not recognized yet as the most common cause of dilated cardiomyopathy. If I look at the clinical exome sequencing, FHOD3, which was found to be the second most common cause of hypertrophic cardiomyopathy in our cohort, was not in this group of genes. So more restrictive one get, there's a higher possibility that something will be missed. But on the other side, if you don't have too many genes, you won't have that many variants of unknown significance, which might be also quite a nightmare when you are interpreting the data. So if we look at the diagnostic yield, here are some studies that have been published in last 10 years. And you can see that in those that survive cardiac arrest, the diagnostic yield, there's a huge range from 0 to almost 80%. That's in those cohorts that are really very good, clinically characterized with a high probability of being an inherited cardiac disease. But on the other side, if we go through those that are phenotypically negative, so to say, even in those, we can find some of those that have a genetic disorder and that have a cardiomyopathy. So what was said was that 80% of those that have really a good definable probable clinical diagnosis were found to have genetic disorder was found in those, in high percent of those that have a definitive or probable clinical diagnosis. But with those that have idiopathic ventricular fibrillation, the diagnostic yield is quite low. But what's also important is that if we make really small panels in those with no known diagnosis, then the probability that we'll find something is little lower. So if we just go for arrhythmia and not for cardiomyopathies, then the diagnostic yield will be lower. When we looked at the numbers, how many of those that were idiopathic, so when no real clinical cause was found under all investigations were found, there are also differences. Some studies shows that the majority of them have arrhythmia inherited disorders. The others said that cardiomyopathies are more common. And here are some genes of those that have already been published when all investigations that were done in these patients showed no abnormalities, but nevertheless genetic testing showed the pathogenic variant. So there are some cardiomyopathies when the arrhythmia might be the first sign of the disease. And I would be eager to see if they will publish this in 10 years so that we can somehow learn how this natural history of disease evolve. Because nowadays, actually, genetics is getting more and more easier and cheaper, although it's not easy and cheap. But at the beginning, we just tested those where we were almost sure that we'll find something. And now we are moving to the field when we are searching also in those when the probability is very low. And we can see also those phenotypes that were previously not recognized. So in our small cohort, we found the cause of those that survive cardiac arrest that have some clinical or subclinical findings in 28%. And genes are more or less somehow similar to previously found. It's also titin that is on this list, and all variants are written on the poster, so I invite you to look at the poster of Nina Vodnio. What I would like to stress is that variants of unknown significance, if we look at the number of variants, outweigh those of likely pathogenic and pathogenic variants. And what I would also like to say is that if we would look at these variants 2 years ago, the diagnostic yield would be lower than today. And this is mainly because of accumulating the data. So we were able to see which variants are recurrent in our population, and some of them could be reclassified from variants of unknown significance then to likely pathogenic variants, which enable us then to make the diagnosis in these patients. Another thing from these variants of unknown significance is that it's quite common that we see them not just one, but more than one, and that they somehow group in the patients with have not a very nice pedigrees. And that's something that was said before, so I will not repeat it. So we mainly look nowadays for these rare variants, but there are others that will probably modify the phenotypes. And this is one of the pedigrees where 3 variants, rare variants, were found, 1 positive and 2 variants of unknown significance. This is another one where also there were 2 half-seeps, one who died at the age of 26 because of sudden cardiac death. This one survived the sudden cardiac arrest. This one died right after the birth and was said to have some cardiac defect, but I couldn't get any documentation. So why to do genetic testing? One thing is that because of the better management, but also because of the relatives. And if we test the relatives, we might also go to the other side and prevent some events. So we know that coronary artery disease are the most common one, but if we look at the incidence of sudden cardiac death, it's much higher in inherited cardiac disorders. And how successful are we with the cascade testing? As previously said, this family has only these 2 members in Slovenia. In this one, we were more successful. Usually, if we look at the literature, it's about 40 to 80%. We were checking in our cohort of patients with hypertrophic cardiomyopathy, about 100 patients. And there were at least 1 family member coming from 78% of families. Knowing this, we have to know that the disease will not be the same in all members. And here is the LGE imaging of the 15-year-old girl who survived cardiac arrest. And that's her mother's LGE imaging. All investigations she had was said to be normal, although one of her sons died and another daughter survived cardiac arrest. And that's my last slide. You are probably aware of this list of secondary findings of American College of Medical Genetics and Genomics. The majority of genes on this list are either from oncogenetics or cardiogenetics. And what we did was that we checked our results of exome and genome sequencing. That's about 15,000 exomes and genomes. And look how many have pathogenic or likely pathogenic variants in any of cardiac genes. And it was found to be 2.3%. And looking from one side, what could said, there are many that we can find now and save some lives. On the other side, we can say, what's the burden cardiologists can still manage if we'll send all these patients, they are not actually patients nowadays, but they are carriers of variants that carry a risk to cardiology department. But I think that's somehow the way we are going to, that we'll try to prevent as early and as much as possible. And with that, I would like to thank my collaborators, Bort Petrolin, who is leading the Institute, Alesh Maurer, who is leading the Center for Mendelian Genomics, Nina Vodnio, who is a PhD student on cardiogenetics, and all you for your attention. Thank you.
Thanks a lot, Karin. I think you highlighted the extremely important problem issue regarding the cascade testing. But unfortunately, we don't have Maria Iescone that should have done a presentation on variant of non-significant. But I think that the main problem is to test, to do a cascade screening when, and based on the variant, we should be careful on that, because for variant of a non-significant, a cascade screening could be extremely tricky. Okay, thanks a lot again.
Yes, it's a pleasure for me to invite to have his speech Professor Robert Janevski from North Macedonia. Is correct?
Yes, thank you.
Janevski,
Yes, it's correct.
Janevski,
yes.
yeah, okay.
Okay, thank you very much. It's a wonderful opportunity here for me to be here with you. Thank you for the invitation. Also, I would like to thank to the Institute of Forensic Medicine for inviting me in this collaborative study that we are working together. As you can see, I am currently working in a private genetic lab, but also you can think about the collaboration, future collaboration between a private and public sector in this kind of field, as this is becoming more and more interesting. Although I worked 25 years in the field of forensic genetics, but mainly population forensic. So briefly, we've started this collaboration a few years ago in the field of accreditation, but in one of the scientific work from a researcher from the Forensic Medicine Institute, Dr. Victoria Belokapowska, which is also here with us, yielded with this data that we are going to show you today. So this study was conducted initially with 60 subjects, examined at the Institute of Forensic Medicine, and of those 30 were sequenced with the Jantoren Gene Studio S5 platform on the set of selected genes for cardiomyopathies and arrhythmias. And we are today going to show you only the new variants that were detected in the sequence data, and that might be interesting for prospective work in the future. As you can see here, some of the variants related to cardiomyopathies are shown, and from all of these data that you can see now, most of the classification are variants of uncertain significance, basically because we don't have enough functional data and to predict what is going to happen with the protein. However, there are two variants that might be interesting for further talk, and this is one, and DSP gene. As you can see, normally population data is gaining up a weight towards classification of variant to pathogenic or likely pathogenic, because these are all new variants. The allele frequency is extremely low, and automatically it's giving a weight towards pathogenicity of a certain variant. As you can see here, this is extremely low frequency. In addition, what is gaining weight is because this is a null variant. Of course, when we have a stop gain, it it is known that it will disturb the protein, the function of the protein, and this is a known mechanism of disease. So we have 480 pathogenic null variants reported in the ClinVar database for this gene. Here are some of the examples, of which 10 variants are in this same exon. So normally, because in this 50 base pair location, there are no known benign variants. Normally, that this is going to additionally given weight of the prediction towards the pathogenicity. The other one is this gene that is also weighing additional gain towards classification of pathogenic or likely pathogenic classification, because it is the variant is in exonic hotspot. And you can see here on the slide that there are 18 pathogenic or likely pathogenic reported variants within this 265 base pair region surrounding the variants in this exon. And without any missense benign variant in this region, which additionally also in some giving some weight towards a moderate pathogenic outcome of this variant. Also, there are, as you can see from the functional data, there are 3 times more pathogenic variant than benign variant for curated missense variant in this gene. And this is also as an additional weight towards classification. So the total number of the pathogenic missense variants is 531 versus the 34 benign missense variant, which is obviously on the upper Z-score for this gene. And as you can see on the slide, it's 3.9. One gene that was from particular interest in this study is, as you can see here on the screen. So we have 1, 2, 3, 4, 5 total variants that were found among these 30 patients, of which this variant here has been found among 7 of the patients. However, I'm going to share some additional information about this variant here, because it is a homozygous frameshift variant, and it's probably causing disruption of the protein and leading to the pathogenic classification. So, additionally, as from the previous slides, as you've seen, this variant is extremely low. It's a new variant that we have found. In the genetics, it's like that because usually when you have a new variant, something that is very rare, you should suppose that this is something that can have a pathogenic variant, because normally this subject didn't have offsprings that further spread this variant. Of course, it's not always like that, but this is something that is also taking into consideration when we are gaining the weight towards the further classification of pathogenicity. So the effect on protein here is the one that is the leading weight. So we have 2 pathogenic null variants that are reported in the ClinVar database, and of which one is in the same exon. So as you can see here, in this variant is not in the last exon, or it is not in the last 50 base pairs in the preliminary exon, meaning that most probably it will affect the protein, thus having some kind of outcome in the physiology later. Of course, when you're working with, as you all already heard today, when you're working with cardiomyopathies, there are some variants that are related to the primary physiological defect. And as you can see here, the variants that are linked with the ion channels, and some of those are also interesting for further evaluation. We think that this one here and this one here could be likely pathogenic. Also, this one is interesting because it has been found in 10 of the 30 examined corpses, probably leading to some further investigation in the near future. So the first one here is likely pathogenic. We are suggesting this kind of classification because there are totally 42 pathogenic or likely pathogenic reported variants within this 200 base pair region around left and right. There are no missense benign variant gaining a weight towards pathogenicity of this variant. Additionally, as all of the other data, it is normally that the population data would additionally gaining a weight toward pathogenicity because it's extremely rare. You can see that here that there are some variants which are very nearby and also very rare and are less frequent than this one. As an additional marker towards the pathogenicity is that there are 3 times more pathogenic variant than benign variant that are already created in this gene. So also there are high number of pathogenic missense variant in this gene. So probably when it happens here, something is very bad for the physiology. So we have totally 243 known pathogenic missense variant here and only 45 benign variant. And that is something that is additionally gaining the weight towards pathogenicity. This is the second variant that is also linked with the ion channels, potassium, and you can see that this is non-truncating and non-synonymous variant, which is located in an exonic hotspot. So there are 9 pathogenic or likely pathogenic reported variants found in this very small 65 base pair region surrounding this variant. And from, as you can see, left and right, there are no benign variants. Also, like the previous one, there are 3 times more pathogenic variant than benign variant that are curated already in this gene. So there are total 303 known pathogenic and only 25 benign variant here. The population data, again, as in the previous variants shows all because of extremely rare, this is extremely rare variant, gain a bit weight. Okay, we have to go a little bit faster. So this is another one gene that is of particular interest because there are 2 variants and both of them were likely pathogenic. Why? Because again, as you can see here, there are 9 pathogenic variants reported in this region, and there are no missense benign variants here, left and right of this. And in addition, here are 238 pathogenic missense variant here versus the 182 benign variant. This is something that we discussed yesterday on the dinner as well. This is one variant which is not certain outcome, but it's very interesting that we have found the heterozygous this variant in all of the examined samples. So this is something that might be interesting for further investigation, because it can, imagine if this is something that is leaning toward pathogenicity, probably if it is a homozygous variant, it would lead to neonatal So what we should do from here, probably we should start thinking about creating some kind of new algorithm about polygenetic risk score, because we have these multiple genes that are gaining weight towards the final outcome. We should also think about proteomics, as we already heard today, because, for instance, the previous variant that I've shown, one of the potential solution is to see what is the outcome on the protein and see if the variant is disturbed in the protein and in which way. And of course, you see this from all the discutant today, establishing of these national or regional registers, because we need to share data and to see if these data are valuable to all of us or to some of the ethical groups, as some of the discutant talked before. I would like, these are a couple of sentences as a further challenges. So we are already, all of us, aware that there are lack of knowledge and comprehension on the fast-paced developments of the genetic testing among the professional which pose an obstacle to access comprehensive testing. And that is true, and that is why we all, today, need to further collaborate between different professionals. So a forensic medicine specialist, forensic genetics specialist, and of course, cardiologists as a primary specialist that are in the everyday connection with the patients. So the national or regional preventive program are needed for regular monitoring of the blood relatives, because it is most important now to prevent further sudden cardiac deaths that are already associated with the known genetic variants. So if we come to this stage, we achieved something as saving some lives in future. So this was the talk for today. Thank you very much.
Thanks a lot. It was very nice presentation. So maybe we will discuss later about genes and variants, because we are very curious. So I'm happy to introduce Dr. Milica Keckarević-Marković. Sorry for my pronunciation. So the title of the presentation is Sudden Cardiac Death and Epilepsy. Is there a role for genetic evidence? Thanks a lot.
Good day, everyone. My name is actually Milica Keckarević-Marković, and I come from the University of Belgrade Faculty of Biology. So we all start with sudden death. Sometimes it can stay unexplained. Sometimes when it's autopsy negative, sometimes it could be of cardiac origin. And in those cases, it can also stay unexplained and is mostly attributed to arrhythmia or arrhythmia as a primary disease or arrhythmia preceding cardiomyopathy.
Sorry, just ask to our colleagues, because, perfect, thank you.
Now, okay. But with people with epilepsy, they are in greater risk of dying of sudden death. The risk is 2 to 3 times more than in general population. The major reason for their premature death is sudden unexpected death in epilepsy. And it is a real burden for people with epilepsy, because 1 in 1,000 of people with epilepsy die of deaths of SADEP every year. The definition is similar, of course, to other sudden type of deaths, but it accounts for people with epilepsy. It could be witnessed or unwitnessed. It could be preceded by seizures, but doesn't have to be. So people with epilepsy are aware of their condition and also their environment, but sometimes, because it can stay actually unexplained, it could not be distinguished from sudden cardiac death. So circumstances that go in favor of SADEP are like that SADEP is more frequent during the night. People are found in bed and while they were sleeping, and it's also they are found in prone position. Unlike that, in sudden cardiac death, it is happening mostly after some excitement, emotional or physical, and even after a loud sound. There are some features that affect and increase the risk for sudden death in epilepsy, and those are epilepsies actually with general tonic-clonic seizures, then refractory epilepsy that is with persistent seizures, and it is always generally drug-resistant epilepsy. Childhood onset epilepsy, epilepsies with frequent seizures, male gender, then comorbidities like developmental delay, and also anti-epileptic drugs could increase the risk of SADEP. And there are three proposed causes of death in SADEP. Those are respiratory dysfunction, cardiac arrhythmia, and postictal generalized EEG suppression that leads to autonomous dysfunction. Generally, during epileptic seizures, there is in the beginning tachycardia and also, in most cases, and also acceleration of breathing. Then it is followed with slowing down of both breathing and heartbeat, and it could finish with apnea and asystole. Those mechanisms could act synergistically, and one can say that SADEP is happening due to cardiorespiratory collapse. What is happening in respiratory dysfunction as a cause of death? Generally, it is thought that it is centrally mediated apnea. This is because of excessive excitation of amygdala nuclei, which leads to excessive inhibition of respiratory centers in the brain. It could be also helped with obstructive apnea, which is due to prone position in respiratory dysfunction. When we talk about cardiac arrhythmia as a possible cause of death, it is known that in more than 80% cases in seizures there is tachycardia that could be followed by ventricular fibrillation, and there are documented cases of near SADEP that were resuscitated with defibrillators. Generally, in people that have underlying arrhythmogenic syndrome, like a prolonged or shortened QT interval, are in greater risk of having cardiac arrhythmia. It is also that taking anti-epileptic drugs could change that interval and make people more prone to cardiac arrhythmia. There is also the existence, actually, people with epilepsy, it is assumed that they have epileptic heart, which is generally heart that is like older heart compared to general population because of many epileptic seizures and catecholaminergic surgeries and stress that heart has. So this heart is more prone to stress and could be and to mechanical and electrical changes. What is happening in postictal EEG suppression? Actually, after the seizure, there is EEG suppression that lasts longer when the seizures are more exhaustive, like general tonic-clonic seizures. So the longer it goes, the greater chance is to die from autonomous dysfunction. Okay, now we come to the genetic, but we know that SADEP and epilepsy, that is major risk of SADEP, are actually heterogeneous phenomena, and they depend on the various of many risks. Among them, there are genetic risks. Due to recent development of high throughput genetic analysis, one could now massively search for genetic basis of many conditions, diseases, and also the risk of genetic basis of SADEP. The main rationale for genetic analysis in SADEP are actually to find genetic basis of possible mechanisms of death, but also of other risk factors that influence the risk of SADEP. This is the main rationale, but the studies are very different from those studies that were analyzing only genes underlying long QT syndrome through gene panels for arrhythmia and epilepsy, whole exome analysis to, of course, whole genome analysis. Also, cohorts of patients that were analyzed from a SADEP, near SADEP. Some analyses were having blood samples. In some cases, it was brain tissue analyzed, and there are different data that are not very much comparable. So we need to extract something from those data, and what we can extract actually is that are channelopathies that could be associated with increased risk of SADEP in a few ways. First, ion channels are expressed both in brain and in heart, and at the same time they could lead to epileptic seizure or just add to epileptic seizures and give a larger risk for cardiac arrhythmia. And it was found and confirmed actually for some types of long QT syndrome, Brigade syndrome, and also it is found that in Dravet syndrome, this is with mostly mutation in sodium channel that is causing actual epilepsy, but it leads also to prolongation of QT interval during the seizures. The other possibility is that besides the cause for epilepsy, there is another cause for a possible dying due cardiac arrhythmia, which lies in, of course, what we have seen many genes that could be arrhythmogenic or cardiomyopathy that could whose first symptom could be arrhythmia. Here's also one red flag, because there were cases, and probably still happening, that people with cardiac arrhythmia were diagnosed actually as people with epilepsy, because after arrhythmic episode comes a convulsive syncope, which could be misdiagnosed as epileptic seizure, and those people actually are treating them with anti-epileptic drugs. They are not helping them, and they are even increasing the risk of them for dying. So EEG of convulsive syncope is very different of EEG of epilepsy seizure. So if done, it could make the difference. Besides those clear connections, there are data from more comprehensive genetic analysis that tell us that there are some enrichments actually in gene variants in gene for ion channels in people with epilepsy and in people who died of SADEP compared to general population. So some of those variants could be and could have been defined as VUC because some of them were found pathogenic in silico, deleterious in silico. Some of them were very rare in the population, but didn't meet ACMG criteria to be classified as pathogenic or likely pathogenic, so they are of uncertain significance, but also there is enrichment of benign and likely benign variants, which can lead us to assumption that actually the co-occurrence of those variants together with the non-genetic risk factors could in additive or maybe sometimes synergistic way lead to increasing the risk of dying. Of course, what is needed, functional studies to see what is happening with the ion channel because of the existing variant. Is it leaking? Is it overreacting? Is it not reacting? And possibly to provide some preventive therapy. Other than the channelopathies, in more comprehensive genetic studies, there were genes associated with the other two mechanisms of dying in SADEP that were also having changes in people who died of SADEP, and also variants in many genes associated with neurotransmission, cell adhesion, cell signaling, transport, metabolism. Some of them could also influencing heart resilience of epileptic heart. So, is there a role for genetics? Definitely it is, but it is not the primary role. It could be generally direct role by influencing mechanism of death, or indirect role underlying another mechanism, another non-genetic risks for dying. On the other hand, we saw about few examples of major genetic risks, but the more of them are actually just contributed together with the circumstances, way of living, and similar factors. So to recap, knowing that this is of major public health issues, and the good news is that epilepsy is visible and recognizable, so one can act in advance. Definitely genetic analysis should be done to find if there are some major risk factors that could increase the risk of death, but also EEG monitoring, ECG monitoring in order to find if there is some underlying arrhythmia to, if possible, to find it and prevent it. And of course, we have a lot of data. Data should and could be unified and of course verified in order to make some artificial intelligence tool for individual prediction and something like that. Thank you for your attention very much.
Thanks a lot, Milica. It was very interesting also because we were talking with Stefano that we should further investigate these events, and so we are doing, we have a quite good experience in this kind of diseases because we are working also with epilepsy patients, and so maybe we can talk later about this important topic.
Yes, thank you.
Yeah, congratulations. Very nice presentation. It's a field I'm really interested in this field, and I think that much more effort we have to dedicate to sudden unexpected death in epilepsy. So, if there are questions for speakers, and if not, we can go to have a light lunch. Just a consideration. I hope all the young researcher presented poster at 2:30 be here in the conference room for the Best Poster Awards. And after that, we continue with a session of cardiologists. Thank you very much, and enjoy your lunch.